Alrighty. Well, good afternoon, good evening, and possibly even good morning to all of our colleagues that are tuning in today. Welcome to TAPS, the Australasian Pleural Seminars, our monthly series highlighting pleural disease on the first Wednesday of every month. So joining us today is Professor Gerben Keijzers, who is a senior emergency physician and clinician researcher at the Gold Coast University Hospital Emergency Department. His research focus has been on encouraging collaborative clinical research. He likes to challenge dogma and focuses on areas where less can be more, such as avoiding unnecessary chest drains. And as one of the lead authors on the 2020 New England Journal of Medicine study, we're excited to have him discuss the conservative management of primary spontaneous pneumothorax today. Now, if all that wasn't impressive enough, when he's not in the hospital, you may find him practicing Brazilian Jiu-Jitsu or taking his two border collies to one of the beautiful beaches on the Gold Coast. And before we begin, a brief reminder for our audience members, please post any questions you have in the chat to help us generate a robust discussion after the presentation. And so now, without any further ado, please join me in welcoming Professor Keijzers.
Hello, everybody. Can I confirm that you can all see the slides?
Yep, we're good to go.
Excellent. Thanks for the introduction, and thanks for Gary Lee to ask me to present, or maybe he didn't quite ask, maybe he told me to present, but still, I'm more than happy to speak to you all today. I'm going to talk to you about conservative management in primary spontaneous pneumothorax, and it'll become clear why I'll have unicorns and a monster of Loch Ness on my opening slide. So I assume that the majority of you are physician trained with respiratory interests, or respiratory physicians or the like, where I'm an emergency physician, and just want to make sure that you don't think of us as cowboys, and that we have a similar mental model of what emergency physicians do. And I guess that it's, in my mind, it's finding the trade-off between speed and accuracy. So I think we need to be quick when we need to be, but probably more importantly, we should make the right decisions and accurate decisions. And I think this comes down quite specifically to the issue of primary spontaneous pneumothorax as well, accuracy over speed. What will I talk about in the next sort of 15 minutes? Is primary spontaneous pneumothorax overtreated? I guess you can probably guess the answer by where we're coming from. I think the answer is yes. But what are the reasons for that overtreating and the interventions that we do? When I say we, I mean clinicians in general, probably primarily emergency physicians, but potentially also clinicians on ward-based settings. I'll talk a little bit about the RCT that was mentioned during the introduction, but also talk a little bit about some data analysis we've done beyond that on that subgroup of patients that have a specifically large pneumothorax, which then leads me to try to answer the question, does size matter, and at what stage does it matter? Obviously, this is a large pneumothorax or near complete pneumothorax. There's a big red arrow on the screen, which must mean that there's something interesting happening. And I guess that this is one of my sort of pet annoyances with radiology reporting, is that they will report this as radiological tension. But reality is that this is obviously a mediastinal shift that is part of normal physiology when you breathe out and the normal healthy lung pulls the mediastinal tissues a little bit to the healthy side. But I think that having this sort of pictures probably perpetuates some clinicians to be reluctant to watch and wait. So why do we intervene? It is an impressive looking picture. And these patients often present with, when it initially happens, they usually have this sudden pain and a degree of dyspnea. And the interesting thing from the RCT, where we recruited probably 25 or 30 patients for, and I followed most of those, is that the great majority of these patients actually have very limited pain that can't be managed with just simple analgesia within 24, 48 hours. And I've never really understood clinicians that say that we should treat the pain with a drain, because treating pain with a painful procedure never really made much sense to me. And then there's a degree of tachycardia, which gets brought up as potential instability. But you would expect a patient who has sudden pain maybe just a change in physiology, plus they're in an emergency department, to have at least some borderline tachycardia. So I don't think a heart rate of 90, 100, or 110 should be an indication to rush to do things. But more importantly, I think we've been taught as medical specialists in medical school that this is a potentially life-threatening condition, and there is a significant degree of clinician anxiety about leaving this alone just because of the way it's been taught over the years. And guidelines up till recently did suggest intervention for these ones. So talking about guidelines, this is the summary statement on spontaneous pneumothorax from the most recent British Thoracic Society guidelines, and it says, with the red little squirrely bit, it says that regardless of size, we can manage these patients conservatively. But then there is this sort of delineation where they say, as long as they're minimally symptomatic. And I guess then the question becomes, what is minimally symptomatic? If they have a little bit of pain and they can function normally, is that minimally symptomatic, or do they have to be completely asymptomatic? You know, I believe that if you can function in your normal daily activities with some degree of, with a mild degree of discomfort, I would call that minimally symptomatic, but this may be in the eye of the beholder, the clinician, as well as the patient. I'm not quite sure if our setting, our hospital, is unique or not, but for some reason we still have routine expiratory films. And I would think that if you can see a primary spontaneous pneumothorax on an inspiratory film, then there is no need for an expiratory film. And the problem with the expiratory films, as you, I'm sure, all know, is that it exaggerates the pathology, and it leads to an exaggeration of that mediastinal shift. So here's a few examples. This is a young fella who came in when he was playing basketball that I saw. He's 16. This is the inspiratory film. This is the expiratory film, which obviously looks pretty impressive. He was managed conservatively. We sent him home after a few hours of observation, and he recovered within 7 weeks without any intervention. This is a fella I saw just after New Year's this year, and again, inspiratory film, and then the expiratory film looks very impressive, but we did the same, and he was actually fine after 6 weeks with no intervention. So why should we intervene in the emergency department, or at all? I think that if patients are significantly hypoxic, despite the initial analgesia, reassurance, and some supplemental oxygen, if they remain persistently hypoxic, I think at that stage we need to consider it. But that period could be several hours. It doesn't have to be a time-critical pull the trigger event straight away. And if they're truly unstable with hypotension, which I must say I haven't seen in the last 20 years as an emergency physician, I would think that that probably means there's some other pathology as well, but I would be happy that that would be a good indication for an emergency intervention. This leads to the concept of, does spontaneous tension pneumothorax even exist? And I'm not sure how many of you are aware of Graham Simpson, who's now a retired respiratory physician from Cairns, who wrote a nice editorial in the Internal Medicine Journal, I think about 2011, highlighting why it's physiologically quite difficult, if not impossible, to get a tension pneumothorax in a spontaneously breathing patient at sea level. So patients with large pneumothoraces, they may well decompensate, but that's probably because their good lung is also diseased, or there's something wrong with it, rather than a true tension mechanism by high interpleural pressures. And I think that that's often my key strategy talking to emergency physicians, saying, well, you know, a tension pneumothorax in spontaneous pneumothorax it probably doesn't exist, and if it does exist, it will be exceedingly rare. And I think that that's almost a talk on itself. So I won't go into too much details, but I'm more than happy to take questions at the end if it's deemed to be controversial. A quick summary of the PSP paper that was now published just over 4 years ago. as most of you probably would know, this is patients with spontaneous pneumothorax, the first episode that had at least a moderate size, so not the small rims, who were then randomized to either getting guideline-based intervention, which essentially meant a Seldinger style small French tube, or conservative management. And of the people who were randomized to the intervention, almost all did receive the intervention. And in the patients that were randomized to watching and waiting, 15% ended up with some form of intervention during their follow-up period. 15%, which is an important proportion to remember, because I'll come back to that proportion later on. These are the other findings of the study. And if you look at the top, you can see that the re-expansion of 8 weeks, that was the non-inferior for both strategies, and the time to symptomatic resolutions was similar, with a slight point estimate preference for the conservative group. But then there was all the patient-centered outcomes, things that patients care about: days in hospital, adverse events, recurrence, number of scans, days of work, that were all markedly better in the conservative group. And then there's another outcome that wasn't really very much emphasized in the paper, but I thought was quite interesting, is that if you were randomized to get the intervention, a drain of some sort, you were 4 times more likely to end up with a cardiothoracic intervention than if you were randomized to the conservative group. So is there some degree of intervention bias? If you receive an intervention early in your patient journey, are you more likely to then go down the cascade of interventions where you may receive a cardiothoracic intervention, but whether you needed it is a whole different story. Interestingly, in the conservative group, about 1 in 10 ended up receiving a cardiothoracic procedure eventually. So over time, clinicians are getting more comfortable with, looking after these patients with observant and conservative management. But in my own setting, I've had some comments about, well, what about the complete collapses? What about the patients who have mediastinal shift? What about the ones that may take a long time to recover? Are they acting differently than the ones that just have a moderate size? And to answer that question, we looked at a subgroup of the RCT, patients who had a collapse size of greater than 80%. So in the conservative group, there was 45 patients who had a near complete or complete pneumothorax, and in the intervention group, that was 50 people. So this is a moderately busy slide, but it's essentially the red circles highlight the patient-centered outcomes for the 45 patients who had a conservative approach and a large pneumothorax, almost complete one, versus the 50 patients who had a complete pneumothorax and received an intervention. And the time to X-ray resolution obviously favors the patients who received a drain. But then the time to symptomatic resolution is actually similar, as is the time to becoming symptom-free, where the time off work favors the conservative group by 4 days, and the hospital length of stay is 5 days shorter in the conservative group, even if you had a complete pneumothorax. Satisfaction similar, X-rays about half, and recurrence rate was similar. But most importantly, the adverse event rate is 4 times higher in the intervention group. And interestingly, in the 4 patients who had an adverse event in the conservative arm, it's actually from crossover to the intervention. So of the 45 who were treated conservatively in ED, 37 was recovered without any intervention, similar to the couple of X-rays I showed at the beginning of the talk, and 8 received interventions during the follow-up. So of those 8, 3 were within the first 24 hours of randomization. But when we looked into the details of why that happened, it seemed to be primarily size concerns, that clinicians who now looked after these patients and may have taken their hand over and said, wow, this is a big pneumothorax, but the vital signs were actually normal. So although these 3 patients ended up with an intervention early after randomization, it's seemingly more due to clinician concern and anxiety rather than true physiological abnormality. The other 5 were all changed to an intervention between 2 to 6 weeks follow-up due to slow re-expansion. And of those 5, 4 ended up with cardiothoracic intervention. So these are people probably having a large air leak of some sort and requiring a VATS, pleurodesis, or retrosection. So in this post hoc analysis from the study, looking at only at the complete or near complete pneumothoraces, 17% got an intervention during the follow-up, which is essentially the same as the 15% for the overall group that I mentioned in the beginning, who ended up with some form of intervention. And consistent with the overall group in the RCT, for these large subgroup, the hospital length of stay, days of work, x-rays, adverse events were all much better in the conservative group. And they had the same time to symptomatic recovery, similar satisfaction, and similar recurrence rate. So that's obviously data from an RCT, and it's post hoc, and it's all in a study setting. What happens in the real world? So I've looked at the data for the last few years in our Gold Coast setting. So these are all patients with a first primary spontaneous pneumothorax that was large, as defined, consistent with the definition of the RCT from 4 years ago. And we have changed practice compared to 10 years ago. Out of the 24, only 3 received an intervention in ED. So that's 12.5%. All of those were obviously admitted to hospital, and 2 out of those 3 ended up with a cardiothoracic intervention. What happened to the remaining 87.5%? Well, 3/4 got discharged directly from our emergency department. And then the remaining 5 got admitted to the ward for observation, probably because there's still some anxiety about the size. And interestingly, all 5 received a drain on the ward due to size concerns. But again, all had normal vital signs. Nobody was actually decompensating. Nobody was hypoxic, tachycardic, or hypotensive. And of those 5, 1 ended up with a cardiothoracic intervention. So now we're talking about 1 in 21. If initially conservatively managed, 1 in 21 got a cardiothoracic intervention. So that's quite a different risk of a cardiothoracic intervention, whether you get initially managed with intervention in ED or with the conservative management in ED. So the conclusion of this talk is that even complete primary spontaneous pneumothorax can be safely managed. A small proportion will still require a cardiothoracic intervention due to slow improvement or failure to re-expand. But I think we need to be looking at the speed versus accuracy argument that I started with and seeing if this delay in definitive cardiothoracic intervention outweighs the unnecessary intervention earlier in the patient journey and all the poorer patient-centered outcomes that go with it. And I would argue that a delay is warranted for most patients. So this is the fella that I saw just after New Year's, and I've shown you this x-ray before. So what do I actually do with this man? So I spoke to him, and I think that sometimes patients say, oh, they did nothing for me. They just sent me away. So I usually signpost doing nothing as an active treatment. I'll say, listen, this is scary. Obviously you've got something going on. We can look after your symptoms. We can make sure that we closely follow you with repeat x-rays through your GP, or if needed, even through the ED, making sure they get appropriate written and verbal instructions of what it actually means, but also saying that there is still a small chance you may end up with a definitive intervention. And then based on all that information, most people are quite happy to share the decision. And I think 9 or 9.5 out of 10 is usually happy to then follow the conservative the strategy. So in summary, I realize I've gone a few minutes longer than I was instructed to. Don't treat the x-ray. If your hospital still uses expiratory films, see if we can get rid of them. I'm trying hard on my side. Treat with analgesia, oxygen reassurance, and instability is pretty rare. And again, think about speed versus accuracy. Intervention in ED leads to overall poorer outcomes. And I think cardiothoracic interventions can be planned. I had a patient who had a recurrence, who was stable, who I called to our cardiothoracic team. I said, rather than putting a drain in, can we just plan them somewhere in the next week or two. And that's what I did. I think one of the key challenges for future researchers will actually trying to find out which patient, which small proportion will actually need that cardiothoracic intervention. And I think that may not be completely clear at this point in time, especially not while they're still in the ED. So that's all for me, and I'll stop sharing. And if there's any questions, I'm more than happy to take any.
All right, perfect. Thank you so much, Professor Keijzers. That was awesome. That was a great review, and more reason why we should be doing conservative management nowadays. So with that, I'll go through our chats here. And Deepan Sivakumar says, have you found GPs to be comfortable following these patients up with X-ray?
Yes. I mean, again, it comes down to communication. And I must say, I am usually quite detailed in my instructions. So I will say, I will put in a letter, I know this is different, and this is a deviation from what's always been done, but this is based on best data and new data. And if you're uncomfortable, we're more than happy to do the X-rays instead. And I often even quote the New England paper and the New British Thoracic Society guidelines in my letter, just to make sure that I'm not just making stuff up. And the ones that I've showed you the X-ray from, and there's probably another dozen that I have like that, I usually give them a follow-up phone call, making sure that A, they're happy, that their GP is on board. But I haven't had any resistance as long as it's communicated clearly. If you just would write a letter saying, patient has pneumothorax, please do a repeat for X-ray, and it's a complete pneumothorax, I think you may end up with some questions. So it does need some clear communication.
Yeah, no, absolutely, you're right. Let me see. Another question that we have is, how strict are you regarding definition of primary spontaneous pneumothorax? Seeing a few in their 30s who have turned out to have bigger blood spilly than expected, how do you account for those when initially assessing?
So I guess that you're right. I mean, I think that this is also one of the criticisms of the original RCT. We included people between 14 and 50. So, and I think that we probably had some secondary pneumothoraces in there. I think at the time, if you don't have a known diagnosis of an underlying condition, I guess the working diagnosis is primary spontaneous pneumothorax. And you're probably right that if there is some undiagnosed COPD, that the chance of an ongoing air leak is going to be larger, and maybe that's representing that 10%. But I think the initial management and the initial treatment wouldn't necessarily be different. But obviously, we need to be keeping in the back of the mind that we may have some undiagnosed secondary that's sitting there. And I guess that probably, when the dust settles in the emergency department, maybe some further history may come about. But I'm not sure if it really truly makes a huge difference for that initial management. But you're right that if you have an undiagnosed COPD who has larger bullae or bleps, that may then change the trajectory. I agree with that. Thank you.
Absolutely. Another question is, how will you follow up repeat X-ray interval between X-ray?
How will I follow up repeat X-ray interval?
Yeah.
So the study used 2, 4, and 8 weeks as the intervals. And I guess that I usually also am quite specific in my instructions to say, listen, I would like you to just do the inspiratory X-ray, because if you have different phases of expiration, you may get an idea that it's getting worse, but the reality is it's actually not getting worse. But I say to the patient, there's no point doing the X-ray in 1, 2, or 3 days, because you wouldn't expect it to improve in that shorter time. So unless you actually get symptomatically way worse, if you're symptomatically the same or better, I usually encourage them to wait at least 2 weeks, because I think that would be the minimum interval to expect some change. And I think then at least you can say you've given it a good go. And if for whatever reason there's clear failure to re-expand, or they've actually gone from 70% collapse to 100% collapse, now you go, okay, I have enough information. But I don't think there's a point in re-X-raying them at day 2 or day 3, unless they truly have a change in clinical scenario. I'm not sure if that answers the question, but that would be my approach for the timing of them and the instructions I would give to the patient and or GP.
Absolutely. Another question is, and this is about patients' kind of decisions. So would a patient who wants to scuba dive, or I guess alternatively flies a lot, change your management, Or would you just refer to CT surgery for planned intervention? How would you approach that, I guess?
So I do ask about those things, and indeed, if they have fly-in, fly-out worker, for example, I think if you have 100% collapsed pneumothorax and it would take 8 weeks for you to re-expand, I think that if you are a fly-in, fly-out worker and that's your source of income, then I think that would change my approach. So again, it needs to be shared decision with the patient, and it needs to take into account the patient preferences and situation. So indeed, if they need to fly, I think I remember I had a Korean guy who had a wedding back in Korea, who we ended up intervening because he was really, really keen to fly. And I think the only way he could fly to that wedding is if he got re-expanded quicker than with conservative management. So again, I'm not saying interventions never indicated, but it shouldn't be a knee-jerk reaction. Scuba diving, I think that the ones they've got a pneumothorax, I'm not quite sure whether they should scuba dive. So scuba diving probably wouldn't change my management. I think I would just say, listen, there's probably the data probably hints to slightly lower occurrence in the conservative group. So if anything, I would probably watch and wait. So I think for flying, it would change my management. For scuba, probably not.
Great. Another question we have is it safe for conservative management in patients that are rural or more than, or far from regional areas greater than, 1 hour from a medical facility?
Yeah, it's hard for me to comment because I'm obviously in sort of in the Gold Coast, which is quite urban. I would think if I had somebody driving in from 2 hours and they had a complete pneumothorax, I would probably watch them in my short stay and make sure that they've settled symptomatically. The fact that the chance that they're going to truly decompensate after having 24 hours of symptoms is close to zero, I would probably base a decision on their common sense, their access to transport. But I don't think I would intervene just because they live a few hours away, but I may watch them a bit longer. But yeah, again, it depends on the human. It depends on whether I think that I can trust their decision making. But again, I think the real risk after having symptoms for 24 hours and it's already complete, if they have common sense, that real risk is probably very, very, very low.
Sure. Absolutely. And the questions keep coming, so I'm just going to keep firing away for a little bit.
No, I'm more than happy to talk. If I'm not happy to talk.
Yeah. So if on follow-up an X-ray remains static, not getting bigger or not resolving, at what point would you consider cardiothoracic referral for slow re-expansion and kind of more definitive management or not?
I've had a few, like, as I said, I led the recruitment for our study, and then pretty much it's become like a little bit of a pet interest. So I must have a pool of at least 60 or 70 of those. And there are people who at 2 weeks seem like they're a bit worse, and I just have a conversation with them. And so, listen, it really all depends on A, what your symptoms are, B, what your expectations are. But I think if everything being the same, you can still watch if you wanted. I mean, if they have a coughing fit or something happened where it changed some pressure gradients that may have caused a little re-expansion, they may still do okay. So I've had several who had seemingly poor re-expansion or even looking that they got worse. We still decided to do nothing and they still went fine. So they may have taken 8 weeks or 10 weeks rather than 4 to 6, but they still went fine. But it's a shared decision. And I think there's been one or two who said, listen, I just want the picture to be better. And I want this episode to be done. And some of them have been referred as well. But I think probably about, in my personal experience, about 3/4 are still happy to be patient, and see how they go.
Great. Absolutely. Yeah. The next question says, so approximately 10% of primary spontaneous pneumothoraces may have a familial component, and assessing for genetic conditions can be a routine part of subspecialist care, so respiratory or pleural physicians. But when following a GP, will they adequately pick up on cases of Burghardt-Dubé, Marfan's, Lamb, anything like that? I guess is the question.
Yeah, no, it's an interesting question, and I think it's probably going to be slightly diplomatic and saying it's probably outside the scope. I have had this discussion with our respiratory team, and they would say that if there's no clinical indications to think about any underlying condition, they would probably only start looking into that if it's a recurrence. If it's just a single primary, they may not rush to that unless there is clinical indicators to look for that. I mean, I remember that we had an A-list download that I recruited that she was super bendy, she had scoliosis, so I thought there's something going on. So I did refer her to the respiratory team for that reason, but that was based on clinical suspicion that there was something else going on than just being a tall, skinny bong smoker. But yeah, I think that you're right that we need to keep that in the back of the mind. And if they're not fitting the normal phenotype or the normal pattern, then that needs to be somewhere in the back of the mind. And whether that's immediate or whether that's when there's a recurrence, I don't know what the answer is. Maybe either yourself or Gary may want to comment on that. But as you say, that's probably a subspecialty decision.
Yeah, no, absolutely. And I think, we're fortunate enough because we have our Pleural team here and we have a great department. We can follow, pretty much every one of our patients that comes in and is sent home for a PSP management. So, I think it's easier for us, obviously, more challenging in smaller hospital settings or rural settings. But no, you're absolutely right that there has to be some, clinical thought as to, and the GPs maybe have to just know that if there is something fishy going on, that referral is important, and they should do it sooner than later. Because I think most people will be happy to see these patients up front than down the line.
Sure.
Next question is a little bit more about hospital management and kind of in the ED specifically, so you may be able to better kind of field this. But so how do you manage ED time targets for treatment and discharge? So if there's a 6-hour target in the ED of most hospitals, it says, do you refer to the medical respiratory teams to observe, or how does that work?
That's a New Zealand question because they have a 6-hour. They have a 6-hour rule. We have a 4-hour. Our national access target is 4 hours. But if you admit a patient to your short stay or observation ward, then the time stops. So if we think that the patient needs to stay longer than the time target, then we can put them in our short stay. To be honest, I would prefer the great majority of the time to make my decision based on what's best for the patient rather than time targets. But we do have ways to go about it and still meet the time targets. I was just telling before we started this talk to Gary that my last patient on my evening shift last night was a primary spontaneous pneumothorax. He was in and out within an hour, so no problems with time targets there.
Very good. Next question is about red flags to request. So any kind of symptoms or any kind of signs that you see where you would consider requesting a CT prior to discharging the patient.
It is not part of my routine. I think that it's been an exception rather than a rule. I mean, if you can see an obvious bulla, you think this doesn't look quite right, then I would probably organize it, whether it's organized in ED or as an as an outpatient one. Obviously, if you've got a complete collapse, you may not necessarily you probably need to wait for a re-expansion to appreciate whether there's bullae or things like that. It's pretty rare that I would, or that we would order a CT as part of the initial workup. I think if you've got a patient who's in their 40s or 50s and they have some potential alternative comorbidities, or you think that this patient is a bit more decompensated than you would expect from a medium-sized collapsed lung, maybe there's some other disease going on, but then they usually need to come into hospital for their symptoms. So, and then usually that would be in consultation and discussion with our respiratory team. So I think that we would probably not, if they're safe for discharge, they probably wouldn't get a CT before discharge. If there is question marks, they often end up getting discussed with our respiratory team who made either plan it as an outpatient or admit them and do it as an inpatient. I'm not sure that answered the question fully, but hopefully at least partially.
No, absolutely. And then we'll take one last question. I know there's a few other questions that are, generating, so I'm glad to see such a robust kind of discussion, but just in the interest of time, we'll take one last question and it goes, so specific threshold of triggers, specific symptoms or level of vital signs to determine intervening for the primary spontaneous pneumothoraces.
Yeah, I think I sort of alluded to during the talk. I'm usually, I think pain can be treated, and usually the ones that I speak to at 24, 48 hours, they almost all do fine on just over-the-counter medication. And usually when you reassure the patient and tell them of the natural trajectory, that actually helps with the analgesia as well. So saying that you got 7 out of 10 pain, but you can do everything normally, I think it comes down to education again. Tachycardia really depends. Do I think that this is pain driven? Do I think this is anxiety driven? Do I think this is actually physiological because of the fact that they have now got a perfused lung that's not ventilating and are waiting for the shunting to happen? So if they're going at 110, 120, I may watch them a bit longer, but I wouldn't necessarily rush to intervening. I think that the reason I would consider intervening is significant hypoxia despite oxygen supplementation and good analgesia. That would be my key trigger, I think. But it hasn't happened yet in the last 15 years, so it's hard to know.
That's right. All right, very good. So again, I want to thank you, everybody, for joining us today. Please do remember that these sessions are recorded and they are available on YouTube to watch at your pleasure. Please do share any feedback you may have for us and join us for our next session, which will be on the 1st of May, when we have Dr. Nicholas Smith from New Zealand discussing pleural tuberculosis. Thanks again, and we'll see you soon.
Thank you. I'll make one more comment if people are still online. I saw one question about oxygen. So
yeah.
So I think that I think the oxygen recommendation is from when oxygen was still healthy and good for everything. That's like I think from a study in the 60s on 12 volunteers. I don't really think that the data to support oxygen as treatment makes much sense, because it's really all about the air leak, and the oxygen isn't going to make the air leak go away. So, and people find it uncomfortable. So I must say, if you look at what the data is based on, the oxygen requirement, the oxygen supplementation, what their recommendation is based on, it's actually really crappy data. So I would not normally recommend oxygen treatment in ED for the resolution of pneumothorax. So it's just some question that I saw come up that I usually like to rant about a little bit.
Yeah. Fair enough. Fair enough. All right. Well, thank you again.
Thanks for having me.
Appreciate your time.
Yeah, thank you.
Bye.